Sure. Hello, everyone. Good morning or good evening, good afternoon, depending upon where you are, and we are everywhere. I am Andrew Spiegel, and I am proud to be the board chair of the World Patients Alliance, and it gives us immense pleasure to extend a warm welcome to everyone today for joining us. And first, I'd like to express our gratitude to our partner, ISQua, for their invaluable support in making this entire event possible. The workshop is a result of a strong partnership between the World Patients Alliance and ISQua. And by partnering with ISQua, we have found that we have a synergy to promote the issue of patient-centered healthcare. And I would like to take a moment to thank them on behalf of the World Patients Alliance. Our organization is only a few years old, but quickly we have already grown to be the world's largest patient organization, working across all diseases, now representing more than 400 patient organizations from 116 countries covering all disease areas. And we're really proud of that, and it fills us with really a lot of pride to have achieved so much in such a short span of time. We're grateful for all of our speakers and our attendees for joining all of our events, and especially joining us today. I also want to thank the staff of the WPA and ISQua staff for their efforts in organizing this event. And with that, I'd like to hand everything over to Karsten.
Thank you, Andrew. Also, a warm welcome to all of you from ISQua, the International Society for Quality in Healthcare. We are proud to co-host this workshop today with the World Patients Alliance, and I think the cooperation between the two organizations is a very good illustration of a sort of co-production where we bring together researchers, practitioners, and the patient's voice. It's an important topic we are taking up today: person-centered care systems, how to bring them from theory to practice. And the workshop is based on a white paper produced by ISQua, and you will see some of the authors of the white paper here today, and it can be downloaded for free on our website. But without much more ado, I'll hand over to Anna, who will moderate the session for us.
Thank you so much, Karsten and Andrew. And good morning, good afternoon, good evening to everybody, wherever you are. Welcome to this workshop co-hosted by the World Patients Alliance and the International Society for Quality in Healthcare. So today we are going to explore person-centered healthcare systems, thinking about the theory behind them and how to actually deliver such systems regardless of where you live or where the care is taking place. My name is Anna Edwards. I will facilitate the workshop today. I'm very proud to be the honorary advisor on person-centered care for the ISQua board. I have been a patient since I was 19 years old, suffering with a chronic bowel condition, which has caused me to have over 30 surgeries and suffer a multitude of complications. I now work for the NHS in England, leading projects and programmes to improve our much-loved health system, the NHS. I'm delighted that today I'm in the company of a fantastic panel of experts, and I'm just going to go through and explain who we've got today and tell you a little bit about them before we kick off with their sessions. So first and foremost, we've got Dr. Gro Berntsen. She is a professor at the Norwegian Centre for eHealth Research. She's worked in the field of eHealth since 2009. Gro researches technology-assisted quality assurance, patient pathways across care boundaries, integrated care, and person-centered care for patients with complex and long-term needs. She has a PhD in osteoporosis epidemiology and was licensed as a medical doctor in 1994. Dr. Berntsen is the lead author of ISQUa's 2022 white paper on person-centered care systems from theory to practice, and she's going to talk about that paper today. Secondly, we have Dr. Anuradha Pichumani. Dr. Pichumani is a laparoscopic surgeon and infertility specialist. She's the executive director of Sri Rengal Hospital in India. And she's also an exec board member of ISQua and a member of ISQua's Person-Centered Care Advisory Committee and the Educational Advisory Committee for ISQua. I'm pleased to say that she was very recently honoured by CAHO, who are the Health Organisations of India, with a Quality Champion Award, and that is as recent as last week. So congratulations, Dr. Pichumani. This award is conferred to recognise outstanding individuals who have demonstrated a significant contribution to the field of healthcare quality. And you're going to hear a bit about that today. She's going to talk about her journey to implement person-centred care at her hospital in India, which she runs with her husband. Thirdly, on our panel, later in the session, we have Penney Cowan. She's the Secretary of the World Patients Alliance. In 1980, Penney founded the American Chronic Pain Association, as she remains their CEO. Penney is a recognised speaker advocating a multidisciplinary approach to pain management. She's been an outspoken advocate and consumer representative for pain issues, contributed to numerous books, videos and websites, consulted on the development of several pain management programs issues, and received numerous awards from organisations such as the Institute for Public Service, the American Pain Society and the American Academy for Pain Medicine. She's worked as a consumer representative for a variety of committees and working groups. And she's the author of Patient or Person Living with Chronic Pain. She's also written all of the manuals and materials used by the American Chronic Pain Association, and she successfully established September as Pain Awareness Month in 2001. So another fantastic speaker. And then last but not least, we've got Regina Kamoga, who is a director at the World Patients Alliance. Regina is Exec Director for Community Health and Information Network in Uganda. This is an organisation that promotes the empowerment of people living with and affected by HIV and AIDS and non-communicable diseases. She's served on numerous health advisory committees and boards at national and international level. She's a past board member of the International Alliance of Patient Organisations, amongst others. Ms. Kamoga works on patient rights, particularly the rights of persons with HIV and AIDS, TB, malaria and other non-communicable diseases, and capacity building for NGOs and community-based organisations on governance and policy issues. She also works on health literacy and access. Ms. Kamoga's work involves building and strengthening networks in collaboration with other organisations at the international, national and community level to address issues of patient safety and patient-centred healthcare. I'm sure you'll agree that's humbling company to be in. So I'm so delighted that they've been kind enough to give up their time to speak today. A couple of housekeeping things. Please do add any questions or comments in the chat box. I urge you to use this with anything you might be thinking so we can truly make this into a workshop where we can discuss ideas and thoughts from across the globe. We'll take these at the end so you've got plenty of time to contribute. Secondly, please make sure you're all on mute so that we're not disturbed throughout the time that the talkers are speaking. So with no further ado, I'm going to pass the virtual mic to Dr. Gro Berntsen, who will kick us off with some key findings from her white paper on person-centered care. Dr. Berntsen, over to you.
Thank you so much, Anna, for that introduction. I'm going to share my screen, and I hope this works flawlessly. Let's see. Okay, can you see this?
Yes, perfect.
Is this?
Yep, that's come up on presentation mode. Thank you.
Okay, thank you. So I'm so happy to be here to be able to talk to you about something I'm very passionate about, person-centered care, and I'm so grateful to ISQua for their part in helping us produce this white paper. In this session, I was presented as a professor in all of those nice titles, but in this work, I was part of this group as a patient partner. And I suspect that's true for almost everyone on this session, that we are both professionals and we also have patient experiences. In this talk, I'm going to go briefly through the white paper, but obviously I won't be able to touch on everything. So I really urge you to visit ISQua's website and download the white paper if you're interested in more details and more depth to the stuff I'll be presenting to you today. So I'll start with three key points that I want you to, that I hope that you will bring with you home after this presentation. First of all, person-centered care is all about partnership. It's a partnership between patients, persons, and their professional helpers, and the sharing of power in making decisions about the patient journey. Secondly, patient-centered care is difficult, and it's difficult due to inherent system properties that we need to find ways of overcoming, and that we are now seeing many different, coming from different directions and making it work from all over the world. This is becoming now a very hot topic for many good reasons. And thirdly, person-centered care, it's not only the right thing to do, but it's also the foundation for successful integrated care and proactive care, which in turn gives better outcomes. So it's not just a nice thing to do. I think it's something that we're going to have to do if we're going to be able to create sustainable care throughout this boom of longevity that we're so lucky to be experiencing all over the world. So before I go into the material, I'd like to thank all of the other patient partners that were part of my part of the person-centered group that ISQua appointed. As you can see, we came from all over the world. This group started working just after the pandemic was starting. So we actually never got to meet each other in person. We have worked totally online and virtually. And we've had, just like now, people have been getting up very, very early and staying up very, very late to take part in our discussions. So there's Fan from Vietnam, there's Sarah from Israel, Morgan from South Africa, Isabella from Brazil, Louise from Liberia, and Carolyn from Canada, and myself from Norway. So when I started this work with this group, I thought that our biggest challenge would be to come together on the same page on what is person-centered care actually. I thought that would, with so many diverse, both cultural and geographic and economic backgrounds, that would be very difficult. But to my surprise, that was not the case. We were on the same page from day one, and we contributed complementary perspectives on what person-centered care is and how we can achieve it. But I think that the unity in our group speaks to the foundational nature of person-centered care. So that was actually very inspiring to understand that this is something that everyone across the globe experienced much more or less in the same way. So why is person-centered care important? And I'm going to answer that question with a small story. Mr. Porter, he's a pediatrician, suffered a spinal cord injury, and while he was in hospital, he experienced the following. Stopping at my room, I could hear the voice of the head nurse with another voice. The next moment, I felt pain on my head as the bandage was truly ripped off the back of my scalp. And I heard a voice say, "Okay, we'll look at it again next week." And then silence. I turned my wheelchair around. There was no one there. So spectacular 21st century technology truly saved my life. But on the other hand, communication between me as a patient and my doctor felt so low that the doctor didn't even feel he had to come around the front of my chair and say, "Good morning, how are you? I've come to look at the sore on the back of your head." And these stories are not hard to come by. I could produce many other stories, but it essentially illustrate one very important point that I think is at the core of why we need this movement in favor of person-centered care. And that is, I've coined it depersonalization. And Cassell, he says that suffering doesn't really arise from physical pain or symptoms or things that ail us. Real suffering arises from the threat to a person's identity and life project. And so being treated as if you're not there is, of course, both disturbing, but also quite harmful. And again, I love this quote from Cassell. He says, physicians' failure, and I always substitute physicians with healthcare because I think this is a problem across healthcare. Physicians' failure to understand the nature of suffering can result in medical intervention that, though technically adequate, not only fails to relieve suffering, but becomes the source of suffering itself. Now, this is very, very important. Here, healthcare is supposed to help patients, but here we're on the track of something that actually we do and which can cause suffering in itself. This cannot continue. So what is person-centered care? Our group took a point of view that starts with this picture. This is a person. This person has has an identity, and this person has some goals, some things that are important to that person in their life. And the WHO defines health as complete well-being in terms of physical, mental, and social well-being. So ill health is actually something that disrupts this well-being. And in many ways, you can see ill health as something that disrupts the person in their life as they're working or somehow trying to do things that matter to them. So when you become a patient, life and care and healthcare are not two separate things. These two things, they coexist simultaneously and they are interwoven. And what we think is very important is that when healthcare comes in, they don't take the patient out of their context, but they look at the patient as a person in a life journey, and that we work together with them towards goals that are meaningful to the patient or to the person and the patient. So person-centered care, according to us, bringing, having that picture in our mind, we said that person-centered care is a sharing of power so that the answer to what matters to you drives care decisions. Patients and professionals co-create the patient journey because they both have knowledge and skill sets that are necessary together. And they do this within the constraints set by the care system to reach goals that are meaningful to the patient. Now, this definition is actually quite simple compared to many other definitions on person-centered care. So if this is simple, why is it so that person-centered care is still so difficult? And I believe that if we don't understand why person-centered care today isn't the norm, we won't actually achieve strengthening person-centered care. So I'm going to drag you through a very brief analysis that points at some important power structures. So in every, this slide is inspired by Donna Bedian, who talks about roles and structures that engage in a process to achieve an outcome. So in this setting, every patient journey, of course, includes a person with a health challenge who at times is a patient. And it always also includes one or more health professionals. And the patient or person is a person most of the time, but when these lines intersect, that person also becomes a patient when they're interacting with healthcare. But those are not the two only roles. There's also the very important role of the care system or the care payer, which is the system that allows, makes a framework for the healthcare team, funds it, makes it work so that healthcare can happen. And then these three structures engage together to create the patient journey. And the patient journey hopefully ends up in these 5 goals that have now been called the quintuple aims. And I'm going to present the quintuple aim a little bit different than usual. I'm going to link the goals to the patient or to the roles. So there's patient experience and health and function that the patient hopes to achieve on their patient journey. The professionals are keen to use their skills and their knowledge to help patients reach their health goals. And then there's the system, which is tasked with not individual health, but population health in a sustainable way. And they also wish to offer this in an equitable way so that the healthcare system is available to all parts of their populations. That's the ideal that we're striving for. So now you will notice that those 5 goals are linked to 3 different roles, and they're not completely, all the 5 goals are important, and they're important simultaneously. But I'd like to point out that there are 2 logics in play here. There's a logic of the person, my health, who's thinking about whose health has been disrupted by health challenges, life is being disrupted, who has a right and a duty to take care of their health, but will need support from healthcare in understanding how to do that, which pills to take, maybe I need surgery, maybe I need training, maybe I need a new skill set. And then also has to weave that healthcare together with their own life and life projects. And on the person side, the goals and the process might be volatile and difficult to define. On the system side, though, we have a logic that is talks of technical excellence, talks of sustainability and cost-benefit ratios that where goals are professionally defined. And I'm quite sure that the second logic very often does not include the volatile, fluid, and difficult to define personal preferences of patients. So now I'm going to sidestep a little bit into theory of complex systems and introduce you to the iceberg model. And the iceberg model says that the events and patterns that we are able to see that are visible to us, such as Mr. Porter's story, they are driven by system structures that are often not immediately visible to us, or it's not immediately obvious to us how the system structures influence the events that we see. And underneath the system structures, there are mental models that underpin how the system is built. And I believe that if we're going to change, if we want to change care to become more person-centered, we have to acknowledge that our mental models are perhaps flawed. I think today's mental model all over the world, it looks like this: the payer, the professional, and the patient are all there, but the power is really here with the payer and the governance and the professional people. And what I'd like to see is the same roles in a new mental model where we explicitly put the patient and what matters to you at the top as our main priority, and that professionals serve patient goals within the constraints of what's realistic, and the system serve professionals within the constraints of what's sustainable. And so all these 3 roles have to kind of co-create the new healthcare system. But the new thing is that the patient and what matters to the patient is at the top of our goal hierarchy. Now, if we want to change things, we also need to be aware of our language. We need a new language because language is power, and we need to include that language into our documentation to make this new mental model tangible. This means that we have to care about and document what matters to patients. We have to translate those into goals for care. And we might want to support those findings with more understanding and curiosity about who is this person who has a health challenge, and how can we best help that person and be together with that person on their patient journey to deal with their health challenges with as little disruption of that person's life as possible. So I like this journey analogy quite well, where the patient is the traveler. Professionals are travel agents. They're not actually traveling with the patients. They're helping the patient find the best way to journey towards their goal. And our mission is to tailor that journey so that we are working towards goals that are meaningful and that the journey is feasible and as comfortable as possible for the patient. Now, there are many benefits to person-centered care, and I just want to go quickly through them. I'm not going to go through the evidence that supports this, just because I don't have time for that. I'm just saying that there is more and more evidence that this actually works, but there's still a lot of ground to be covered where we still need a lot of research. So person-centered care, first benefit is that to recognize and see the person in the patient, it's simply the right thing to do. See the patient in all their messiness and beauty, and that's what life is. Secondly, there is a magic to person-centered care in the sense that if you define a common goal for all for the complex healthcare, which is now very fragmented all over the world, defining a common goal has the effect of coordinating all the efforts. And the only person who has the legitimacy to make an overarching goal is the person, him, herself. And so integrated care relies on the common goal that comes from the person. And that's how you can figure out how to work in a team, who does what in terms of achieving those goals that are important for the person. And my second claim is that person-centered care also leads to proactive care, in the sense that the patient is an active collaborator who is in charge of their health. He or she is always there. He or she has the most to gain from having their health treated well, and they're actually the cheapest labor around. So every preventive and proactive care setup relies on that partnership with the patient, where the patient is involved and engaged and where this works. And if you think about it, professional services are in the picture just a fraction of the time that patients self-manage their own care. And so our job is to be there together with the patient, supporting the patient and doing what's right for them. But then we cannot be setting goals for them. They have to be setting the goals that are meaningful for themselves. So here's my dream healthcare system. It's a system where we put all of these pieces together. We start always with what matters to you and glean goals that are relevant for care from that conversation. And we see the person as part of a family, of a community. On the other side is the collaborating part, the healthcare system, which is now very fragmented, but where we have to work together in order to work seamlessly with the person. And together with that, we create a proactive care plan that relates to and is bound to the goals that are meaningful for patients. I've put in that this is obviously complex. We need a good information flow between all these actors so that everyone knows what the goals are and who does what, when. And finally, we also need the payer governance framework that allows us to do this and fund this and organize this in a legal and socially good way. So this is my dream for my future healthcare system. And I'm going to end this short presentation by encouraging you again to go and look at the white paper, and end with this quote from the white paper. Care professionals are visitors in patient's life. The patient is the host, the guide, and the enabler of the healing journey. And the care system's goal is to enable the person to thrive in their life with as little support from healthcare as possible. Thank you so much.
Thank you, Dr. Berntsen. That's really, really helpful. Lots to think about there. But let's hold those thoughts. Keep putting your questions in the Q&A box. I'm going to hand straight over to Dr. Pichumani, who's going to take some of this theory and tell us her experience of what it means in practice. Dr. Pichumani, over to you.
Is my slide visible?
Yes, we can see it. Thank you.
Okay. So thank you, Anna. And thank you, Carsten. And good morning and good evening to all of you across the world. So I would like to thank ISQua and the World Patient Alliance for giving me this opportunity to share my experiences in implementing this person-centered care systems in a hospital in southernmost part of India. So as Gro Berntsen has already discussed in the previous session, implementing person-centered care, you need to shift the culture of the whole hospital. So you need to be more, it has to be a structured approach, and you have to emphasize the patient's choice, the patient preferences. And I'm sure that all of us have been implementing patient-centered care in various ways. So we will now analyze and look at various opportunities where we can integrate this person-centered care systems into our daily practice. And I will be referring to this white paper, which is absolutely good. Very good, thanks to Gro and the team. And you will see me referring to it on and off. So how are we going to make person-centered care the norm? So as Gro has already told us, you need to redesign the care. So this is the new mental model, and you have to change from the profession-centered to the person-centered, from doctors to the person. Again, it has to be professionally defined outcomes to what matters to you. And again, we need to shift our thinking from diagnostic-specific pathways to the patient journeys. So to introduce our hospital, I come from, I run the Sriranga Hospital in Chengalpet. This is a 50-bedded multi-specialty hospital. It is located in India in the southernmost part. And I run it along with my husband, who is a diabetologist. And we have been running this hospital for more than 31 years. And we cater to the various villages across this area. And so we have rural population and semi-urban population. So when we start thinking about person-centered care, the top leadership is very important, and the culture of the organization. So we need to weave this whole person-centered care into our organization. So for that, we need to redesign our process. And this is the way we have done it. And I am going to show these examples because you need to redesign the whole system. You need to start listening to the patient voice, use various change management, using various quality tools, using a patient journey, and see how the system is going to support you. And again, you need to collaborate with the community, have patient engagements to improve patient safety, and use some digital tools, and also start forming the PF-CAC Council. And last but not the least, you need to measure and evaluate all these person-centered outcomes so that we know where we stand. So I'll give you certain examples from 1 to 9, what we did in our hospital. This is the first one, the system redesign process. So this we did an experience-based code design project in our hospital. So this is improving the patient and staff experiences, changing redesigning the whole system. User-based, user-centered orientation happens, and it is a collaborative change where both the staff and the patient work together. So we started, this is from King's Fund Toolkit UK, and we had facilitators who were trained in these principles, and then we did the various interviews, and we created short videos, and then had a joint patient and staff event, and they started forming the co-design groups, and we started checking the improvements. So this we did in our dialysis department, and we had facilitators, and joint viewing was done of the edited videos. We discuss and prioritize various touch points, because what we think which is important is not that important for the patient, whereas we had to listen to patient's voice. And we prioritize various issues. It was around 36, and we started stratifying these prioritized issues. And based on this, we started changing the whole process. They wanted some wheelchairs. We improved the dining space area. The network was upgraded. So these were various changes which we did based on the staff and the patient's voice, and they had done this. And when we took a feedback, the patient satisfaction improved to 81, and the staff satisfaction was at 87. So next, moving on to the listening of patient voice. That is what Gro referred to as the WMTY, what matters to you. This is an important framework, and we need to listen to patient voice. So the patient's voice, we can either take it as a questionnaire, or it can be interviews which can be done. So it has to be analyzed properly. And so we started doing this in our labor rooms now. So all women have a right to have a positive childbirth experience. And this is very important, because delivery is a multifaceted experience. So we had two papers. One was the Together for Her, and another was the Childbirth Experience Questionnaire. We wanted to check the patient experience. So when we started listening to the patient voice, we were able to see the quality of care indicators, which is given by the Together for Her, where they check various indicators of the infrastructure, the mother and child boarding, whether the staff are courteous. These are the various 9 indicators which are checked with the questionnaire. I had translated it into the local language, and based on this, we were able to check the satisfaction of the patient. It was at 88, and then moved on to 90 because we did certain interventions based on the patient's voice. Again, we listen to the patient's voice. This is a childbirth experience questionnaire. It's a validated questionnaire with 22 questions. So it's called the CEQ. And again, I translated it into the local language here. And this CEQ measures the important dimensions of the first childbirth experience for every patient. None of us will forget our childbirth experience. As a woman, it's very important. So we wanted to measure the different aspects so that it improves the patient safety also. So based on this, we did certain interventions based on the answers that we did analysis. We were able to improve the communication, improve the positive childbirth experience, and the experience also started improving. The third part, what I was talking to you was, how are you going to do a change management? So change management is very important when you are going to do a complex area. So hospital is always a complex organization. So you need to do a change management with the help of quality tools. So the easy quality tool is to have a PDSA. So the plan, do, check, act cycle is very important, where you're going to involve your patients to plan, identify your problems, and then you're going to test something, and then you're going to study the results and then act based on this given the solution. So when you're going to add this PDSA along with the person-centered care, it adds on to the value. So what we did was we implemented this in our labor room again, where we wanted to have every woman who is delivering in a hospital to have a birth companion. Because having a birth companion is very important given by WHO, and it improves the respectful maternity care. So we went through 3 PDSA cycles. These were the 3 cycles which we went through. We started in June and completed the 3rd cycle in February now. And these were the various interventions which we did. We improved the staff training in the first cycle, improved the sensitization of the consultants. Then in the second cycle, we did certain more other interventions. We asked the nurses to put up the forms which were filled on the WhatsApp group, and the sensitization was done. And we started seeing the birth companion, the persons who were allowed for delivery was at 62, and it moved on to 97% now. So this is the change when we are going to do it with a quality tool, and patient satisfaction also improves. And these were the various questionnaires which we had. And as we move from June to March, the first box is for the questionnaire for the patients. The second box is for the questionnaire for the caregivers, what we did. And as we move from June to March, you see more of green. Green represents the score is more by the patients and the caregivers. And based on this score, we started implementing certain questions. And again, listening to patients' voice, we were able to identify that patients were more worried about these 3 aspects out of the 22. So one was about the counseling, the second was the birth companion support, and third was the networking. So we did certain interventions to improve this, and you will be able to see the improvement throughout. Moving on, we were talking about the person, the journey, and the goal. So this is very important, using the patient journey. And when you're going to use the patient journey, we increase the efficiency of the whole system. You're going to streamline the process. You're going to improve the communication and minimize the care gaps, which can happen. So it's very important that we talk about this patient journey and what we did in our hospital. We started mapping the patient journey to improve the system in the pharmacy. So we used this along with the experience-based co-design. So we did a project planning and analysis. So the patient and staff were participating to map the patient journey in the hospital, and they prioritized certain solutions, and we did the stratification again. And we had various co-design groups looking at the patient journey. And based on this patient journey and the experience-based co-design, we were able to improve the pharmacy. We relocated it into a new expanded area. Whatever the patient and the staff wanted, we were able to provide. So whenever we plan a patient journey, the system has to support. Only if the system supports, you will be able to implement it. So the implementation is more important rather than having it on a white paper. So we started implementing it after the ABCD. The whole project was aligned to the organization priorities, and this is a low-cost technique. So we started seeing the patient satisfaction, which moved on to 82%, and the staff satisfaction, which moved on to 71%. Moving on, this is the collaboration with the community. When we talk about person-centered care, you have to collaborate with, as organizations, as hospitals, they have to collaborate with the community. So when you collaborate with the community, it starts building the trust with the community. It provides us with the effective delivery of whatever care we are going to give. And again, it enhances the understanding of the patient. So last 20 years, we have been into the community. From the hospital, we have been running various free camps. Moreover, India is the diabetic capital of the world. And so we had to talk on non-communicable diseases. So to do the NCD screening, we set up various camps in various villages. We had our staff who were doing this. We involved the community leaders in every village. And again, for cancer screening, to improve the patient's experience, we started taking the help of an NGO organization where the bus was retrofitted with a mammography unit and a pap smear. So all the women cancer screening was done in their own villages. Our team went to their villages and they started doing it. And these are the statistics of how many camps we have done last 20 years. And again, with this collaboration with the community, we came up with various innovative ideas. So these are the various puppet shows which we started doing so that to create awareness about diabetes in the community. This was a very new concept. And these are all life-size puppets which we use, and our staff members do this puppet shows. And we have various diet exhibitions. We have various competitions for these students and in the schools and colleges. We have started creating various awareness programs in the whole district so that we talk to them about lifestyle conditions and reduce obesity. Moving on, this is about the patient engagement. So we need to engage patients in the patient safety, and this is very important when we are talking about person-centered care. So this is about a medication safety project which we did when we started out in the World Patient Safety Day last September. So person-centered care in medication safety, you have shared decision-making. You are talking about the 5 moments of medication safety, where we use various audiovisual aids to teach the patients. We ask the patients to know, check, and ask before they start taking any medications. We are demystifying them, the medications. We are using a collaborative medication review, reducing the medication burden, and mapping the journey. We ask them to report any adverse event which happens. Moving on, this is the digital tool. The usage of digital tool is a very important program in any person-centered care. So you will be able to do a personalized care using a digital tool. Though ours is a very small hospital and we are practicing in a semi-rural area, so we had various challenges in implementing various programs. So we took the help of digital tools. When we started out ICU 10 years ago, so there was no trained intensivist to run the organization. So we took the help of tele-ICU. We collaborated with a tele-ICU partner, and intensivists sitting across so many kilometers, thousands of kilometers away. They were able to collaborate with us, talk to our patients, and talk to our doctors who were here inside the hospital, and the patient care started improving. So this is about the tele-ICU. Again, tele-ophthalmology. Since we practice diabetes here, we wanted to take the help of diabetic retinopathy screening. So patients were not, they were not made to wait for so much of time, or they were not sent out. We took the help of tele-ophthalmology, and we were able to send the retinal pictures to the ophthalmologist sitting across kilometers. Again, we took the help of teleradiology to get the reporting within 20 minutes. So we have it in another state. The radiology reports come to us within a short period of time, and we are able to improve the patient satisfaction. Again, we took the help of teleconsultation and telemonitoring, which we started during the COVID period, and it's still continuing. And again, you can use digital tools to improve the proactive care for person-centered care. So this is a continuous glucose monitoring, which we use so that the patients send the reports to the doctors, and our doctors are able to give them a proper care based on these reports. Again, we have taken the help of continuous blood pressure monitoring cuffs. We have vein locators based on the patient's feedback, because when the patients are repeatedly poked to get to search for a line. So these are certain things which we got on the feedback, and so we took the help of a digital tool which is called the vein locator, and this helps us to either collect the blood or start the IV line. And again, we have the electronic medical records, the e-prescriptions which happen, so that the patients are able to check the records and doctors are able to improve the care delivery. Moving on, we have formed the Patient and Family Advisory Councils. So this is the Sriranga Patient and Family Advisory Committee, which we have formed in the hospital. And this helps us to improve the patient experience. The patient's voice is important. The family has to take part in these committees, so that we try to improve the experience, whatever patients has inside the hospital. And to implement a person's the PF Care Council inside the hospital, it has to be a step-by-step approach. And you need to have a PF Care coordinator in the hospital. The training of this PF Care coordinator is very important, because this is the important person who is going to coordinate between the organization and between this committee. So they have to take care of running the committee, implementing whatever is given in the committee, so that the person-centered care happens inside the hospital. For this, you need to create the awareness of the role of patient and family members in hospital, which ISQua and WPA are doing now. So we have these committees which help us to run the organization, and at the end of it, you need to measure and evaluate whatever you are doing inside the hospital. So for this, we take the help of various qualitative and quantitative experience measures. You decide the qualitative tool, what you are going to use based on the study. So this is one of the measurement of the patient experience, what we did in our dialysis department. So this is a PREM study, which is given by NHS, and this has been designed by the patients and professionals working together. They have they inform how the patients feel about the services which the dialysis unit provides inside the hospital. This is a 43-item questionnaire. So I have translated into our local language for our hospital, and this is the heat map what we have taken based on all the questions. The more green it is, the more the score is. And so based on this score, we had done the analysis, and out of the 12 areas, we were able to find out these were the 3 areas which we needed to improve on: the access to the renal team, the information which they wanted, and the transport. So we did various interventions inside the hospital, and we were also able to identify which were the patients who needed additional help. So these are various questionnaires which help us to improve the experience again. So as you saw, person-centered care has various benefits which can lead to proactive care, integrated care, and improved outcomes. We are able to improve the patient satisfaction, help to maintain healthy behaviors. The patients are more involved in the decisions, and we have improved satisfaction among the professionals. So we are coming back to this first slide. How are we going to make person-centered care the norm? So every system is perfectly designed to get the results it gets. So you have to change the system as a leader. You have to redesign it so that you get whatever result you want. So you have to systematically redesign the organization, because when you see the usual system, the patient and the system meeting, patient just meets the doctor. So in between, there is so many issues which are happening. So you need to change the system's goal, which has to be diagnosis-centered, episodic and reactive care, to a more integrated and proactive care, which has to be person-centered. This is the way you start redesigning the organization. And as we saw, this is a very important quote, which I would like to emphasize. Care professionals are visitors in patient's life. The patient is the host. He is the guide, and he is the enabler of the healing journey. So the care system's goal is to enable the person to thrive in their life with as little support from the healthcare as possible. So I would like to leave you all with this quote. People will forget what you said. People will forget what you did. But people will never forget how you made them feel. Thank you all.
Wow, Dr. Pichumani, you are a woman on a mission, and what a fantastic mission to be on. Thank you for everything you're doing in your hospital. It's so wonderful to hear. And I love that quote. It's so true. I can tell you so many stories of how people have made me feel as a patient. It's very, very important. And I like that we've had some real sort of synergies between our speakers today. You know, Dr. Berntsen has talked about changing where the power sits, which is so important. And she said patients are the cheapest workforce we have, which is so true. It's so true. And Dr. Pichumani, you've made clear that this isn't just about the interaction between the patient and the professional. It's also about, you know, the estate. It's about involving patients in policy making, in equipment. So there's more to it. And so I think that's a really important message, particularly given your patient satisfaction scores, which seem to have improved phenomenally. So thank you both. I'm going to move us into a panel discussion. We don't have as much time for this panel discussion as we'd hoped, but we'll try and keep going for around about 10 minutes. And we're going to bring in our two fantastic patient representatives as well. And I know we've got a couple of questions in the Q&A, and I'll come to those in a minute, but I just want to bring our patient representatives in, please, and ask both of them, Regina and Penney, you know, why is this topic so important? Why are we all here today talking about it? Penney, shall I bring you in first?
Sure. I think one of the things that some of us tend to forget sometimes, at some point in our life, we're always going to be a patient. And that's the first thing, but we're really always a person. And I think one of the things are, you know, we tend to be a passive patient rather than an active participant in our healthcare. So I think it's really important that we make sure that our voice is heard. Ask for the healthcare professional to ask that individual, what's your goal in treatment? Even just coming from the pain space, so often they assume it's to get rid of the pain, but if they actually ask people, it's amazing. I mean, there have been studies on, you know, primary cares and asking that individual what is their goal, and it's a very simple. Sometimes it's holding a child or walking upstairs. I mean, we want to make sure that that person with pain, and I always talk, I don't like to call them patients, because unless they're in front of their healthcare provider, they're a person. When they're in front of their healthcare provider, as soon as they walk out that door, they're a person again. And so often people say chronic pain patient, but they're a person with pain, and that's how I refer to myself. But anyway, it's really important to understand what our goals are and to make sure that our voice is heard and that we're the center of care, that we are at the center of the treatment team. We have to be part of that treatment team, not a bystander, but we have to be in the center of the team.
Thank you, Penney. Completely agree. Regina, is there anything you would add to that?
Yeah, sure. And for me, the recognition that I'm just not a body, but a passive receiver of care, but one with a mind who can make contribution to their treatment processes, to be part of the decisions. I think for me, that alone makes a whole difference. I can't forget the Anu's quote, which said, people not forget how you made them feel. Like you said, we all have stories. And believe me, we never forget how they made us feel, whether bad, and amazingly, we always remember the bad ones. But involving us in the process, working with us, understanding that we have not only physical needs, but also emotional needs. That is very critical. As we've seen in Dr. Anu's presentation, you see how patient involvement has made a whole difference in very, very small things which they could otherwise have not thought about. And that leads to patient satisfaction, the experience, and ultimately the outcomes.
Thank you, Regina. I agree. I think we all want to go and be treated in Dr. Pichumani's hospital. Sounds Sounds like a brilliant space. Okay, so we have a question from Natalie here. How can we achieve person-centered care in low-resourced areas with low levels of educational backgrounds? Who wants to answer this question?
I can start, and I think part of it is somehow to empower them, and it may be within community meetings to, you know, to have, and it's going to take the healthcare professional to get involved, just like we saw and heard from Dr. Pichumani, that they have to be the ones to say, you know, you have certain rights, and we want to hear what you have to say. So how do we do that? It's a matter of working as a team rather than individuals. So, but a lot of it is empowering that individual in those areas and having them say, you know, I have certain rights. I want to be treated with respect. I have questions, and look at me as a person, not as the disease itself. I mean, that's just a small part of us. So, you know, I think we need to be able to begin to empower them. This is a first step right here. But I think all of these little small organizations, all of these people involved, to get them more involved too, to keep talking. I mean, it's a topic that is so very important. As I said, we're all going to be a patient at some point in our life, even the healthcare professionals. So it's important for us to work together and to really educate these people, empower them. So if there's anyone in their small community that has that ability, let's engage them and begin to work with them.
Thank you, Penney. And Dr. Berntsen, I'm mindful that the white paper was written by people from all over the world, and you showed us that slide at the beginning. Is this something that you picked out in your findings? Could you
Absolutely. I just want to second what Penney just said. Actually, I was very concerned about the same thing. Is this person-centeredness something that we can only do in affluent countries, in high-income countries? But my colleagues from Liberia, South Africa, Vietnam, they all said, no, it's actually more important, because the person is maybe in a situation where you're very vulnerable, you have few resources, and then it's even more important to not be met in a way that's abusive or that's experienced as harmful, because you're not seen as a person. Secondly, person-centered care helps us target our interventions so that we're actually doing what matters to the patient. Now, that's a conversation. What is it that's most important to do? And that has to be a conversation. Maybe we're using our resources for something that the patient actually doesn't care about, and that's a waste. So in low resource settings, it's even more important than it is in high resource settings to have that dialogue about what matters most here and how can we support you in your life to be as healthy as possible.
Thank you. That's helpful. I'm going to move on to another question. Forgive me. It says, is the HCA HPS a good tool for measuring the patient experience? Are there other tools that you would recommend? Dr. Pichumani, are you aware of this tool?
Yeah, thank you for that question. But I think it is more for the US where these tools are available, and it is related to the insurance. So people have to fill up this tool. It is related to the patient experience, and as soon as the patient gets discharged, I think this survey is sent to the patients, and then they fill it up and send it back. And based on the scoring, the insurance now gives back some amount. So this is linked to that insurance now, and that's how this scoring is happening. So I don't have experience using it because it's specifically available in United States. I think Ms. Penney or someone can take it up.
Yeah, that's exactly right. After any visit that we have, we get sent a survey, and we have to not only talk about the the physician or nurse practitioner or whatever, but they want to know about the office staff. They want to know everything. And it's all based on insurance, but it's also based on the performance of each individual. So the actual provider gets rated based on what we say about them. And that's something that's been put into. Find it, very valuable to give us a voice. I mean, they're always sort of evaluating us, but it was an opportunity for us to evaluate the provider. So that sort of brings it in as a team approach, which is exactly what patient-centered care should be, is that we work as a team and we see each other as equal. So they don't only just look at us and evaluate, but we're allowed to actually now look at them and do the same thing. The problem is you have to have internet access to do this. And so it's going to eliminate a lot of people. We assume that everybody in the US is rich and has all this, but they don't. I mean, there's a lot of rural areas where they have, and in inner city where they don't have any of that. And they're probably, looked at very differently than somebody who lives in a nice, suburban area. There's a huge difference in the United States too, how people are treated. And there's been surveys on that as well.
Thank you, Penny. And thank you for clearing up what it was, because I wasn't aware. And I think in England we've got perhaps a similar thing, which does the same. We have run over. What I'd like to do before we close the session is just ask each one of our 4 panelists if there was one thing you would prioritise in order to achieve person-centered care, regardless of the setting, regardless of the way the health system is set up, how much financial support it has, regardless of whether you're accessing primary care or secondary care, what is the one thing that you would say you should prioritise? And it's okay if you repeat others. So I'm going to start, Penny, you're on my screen, so I'll start with you.
Okay, so I think for me, it would be talking to that individual and letting them know that they have as much power as their healthcare professional. Remember, we're paying them for the services. They're not there for us. I mean, they're there for us. We're not there for them. We're not there to fill. So empowering that person and letting them know that they have the same rights as anybody else and that they're not their disease. They are still a person, and whatever is their problem isn't defining who they are.
Thank you, Penny. And that goes back to Dr. Berntsen's model, really, about that power balance. So I'll come to you, Dr. Berntsen.
Oh, thank you. First, I'd like to say that what a wonderful example, Dr. I'm not good at saying your name, Anu, that you've what wonderful work. And I think you illustrate very well what's most important, and that is to listen to the patient voice in 10 different ways and giving that voice power. It's not enough to listen, you have to act. You have to act on that voice, and that's what you have done. And I'm just so amazed and so impressed by the work that you've shown us today. So thank you for sharing that.
Thank you, Gro. And one thing you think should be prioritized?
Well, that would be it. Listening to the patient in 10 different ways. I'd ask our health service providers to create, challenge them. 10 different ways of how you're listening to your patients individually, in terms of diagnosis groups, in terms of putting them on your board, in terms of making questionnaires, in terms of creating community outreach sessions, all of those places where you can listen and get feedback on how can we support your health. That would be my one biggest priority. Make the patient voice count.
10 different ways. That might be the name of the next white paper, right?
Yeah.
Dr. Pichumani.
Yeah, thank you, Anna. So thank you all for this whole wonderful session. But I would like to thank my team and my husband, Dr. Pichumani, because the whole wonderful journey which has been going on for these last 3 decades is because of the teamwork. And the one thing which I will prioritize will be talking to the leader. So the leader of the organization is the most important person. He can create all the changes. He can empower the patient. He can empower the doctors. He can talk to the staff, and that person can talk to the nurses also. So this prioritization is very important because this is a huge barrier which is there across every organization. Most of the physicians think that it is more time consuming when we talk about the person-centered care. They feel it is very risky if you start listening to patients. And again, there is a sharing of power as we discussed. So these are things which we have to bring it out and open, start talking to other leaders, and they have to implement it in every walk of life. Whenever they get into the hospital, whenever they're going to talk to patients, it has to be done. So we need champions to do this. We need ambassadors to do this. We need PFCAT coordinators. So we need person and family-centered advisory councils, which will be run by a PFCAT coordinator. Like a quality champion, this PFCAT coordinator has to be given a huge role to implement this person-centered care in every hospital. Thank you, Anna.
Thank you, Dr. Pichumani. Great comments. And Regina, over to you.
Yeah, thank you very much, Anna. I think it's again patient, family, and community engagement and empowerment. And I'm so glad that the WHO Patient Safety Global Action Plan has put strategic objective 4 as patient, family, and community engagement, which again emphasizes the need that the patient voice needs to be at the center, because many times patients are not empowered enough to even know their rights. And especially where I come from, they look at the doctor as a small god. So many times they can't even be confident enough to talk about their needs and preferences. So for me, it would be engaging, empowering, and making sure that they can engage as equal partners in healthcare.
Thank you, Regina. That's so true. Wonderful. Well, thank you to all our speakers, our panelists today. A lot of food for thought. There's never enough time, is there, in these sessions? And there's an awful lot that I think many of us would like to say and contribute. But I think we've had an awful lot of insight. So I certainly am going to take it away and really think about what it means for me as a patient, and also when I'm accessing care, and what feedback and help I can give my professionals and clinicians in order to change that power balance. I'm going to hand over to Hussein Jaffrey now, who's going to close the session for us. But thank you all for joining from me, and thank you to our speakers and panelists. Hussein.
Yeah, thanks, Anna. And I'm very pleased that World Patient Alliance and ISQua have been able to bring together healthcare providers and patients to discuss a very important healthcare issue. Person-centered healthcare is a topic on which different healthcare stakeholders may have different understanding. And this workshop on person-centered healthcare highlighted and informed about this very important issue. Moreover, there has been an excellent discussion as well at the end, which will really help us in reaching a shared understanding of person-centered healthcare. There are not many platforms where patients and healthcare providers get a chance to discuss important healthcare issues. So I'm glad that our collaboration with ISQua has really provided that platform, where we can come and organize such similar events in future as well. I'm extremely grateful to Dr. Gro Berntsen for introducing us to the white paper on person-centered healthcare. I'm also very grateful to Dr. Anuradha Pichumani for providing the practical example of how person-centered healthcare is implemented in a small town hospital. So that's really incredible. Special thanks to our panelists, Penney, Cowan, and Regina, Kamoga, for bringing in the perspective of patients on patient-centered healthcare. And special thanks also to Anna Edwards, to you, for moderating this workshop. I'm also thankful to all the participants of the workshop, and I'm sure that there are going to be many more of such events. So stay tuned. Thank you very much.
Thank you, everyone.
All right, guys, bye-bye.